Thank you for listening to Mormon Sex Info. This episode is an archived episode and is only now becoming publicly available. Mormon Sex Info relies on contributions. To contribute, please visit mormonsex.info. And now, please enjoy this episode.
Hello and welcome to Mormon Sex Info. This is Natasha Helfer-Parker, and today I'm really thrilled to have our guest, who is Megan Torrey-Payne. She just gave a presentation at ASECT last summer that I actually attended. It was called Bringing Perimenopause into the Light, and she did that with one of her colleagues, Lori Wagner, and I really found it very useful, lots of great information, and a topic that we don't often talk enough about. Had several people just contact me about wanting some information around menopause in general and how it affects our sexuality, our lives in general, our relationships. So I'm really excited about this topic. Now, as far as I know, Megan, I don't know much about you, so I want you to introduce yourself, but you work out of California, if I'm correct, and you are a certified sex therapist.
Yes, I am.
Through ASECT. And you're a licensed clinical social worker. So other than that, tell us a little bit more about yourself.
So I live and work in Southern California in Pasadena, and I've been practicing since about 2000. So it's about 18 years. And I've been focused on sex and sexuality since about 2007 and certified since 2012. And since then, my practice has switched from a generalist focus to really looking at relationships and sex. I work with individuals and couples and around all areas of their relationship and sexuality. So it might be how to communicate about sex. It might be what's working, what's not working, how to improve it, how to take it where they want it to go.
Wonderful. Well, thank you so much. So I'm excited to probably use the first third of this interview just educating us about menopause. I know one of your first slides that you had on was even just the words premenopausal, menopause, postmenopausal, and perimenopausal, right? So
there's a lot of words that are all very
menopausal words. Yes.
Yes.
And just as a I remember back in college learning about female anatomy at the level where I thought it was finally correct what I was learning, and being so incensed I didn't know these things earlier on, in my life. And that's just kind of how I'm feeling. I mean, I'm 46, and so I'm in this space of life, and I'm a sex therapist on top of it. And yeah, I went to your presentation for a reason. Right. And I feel like once again, as a woman, I'm not very highly educated about my own system, even in my own profession. And so really excited for you to just share basic information that I'm not sure is always very much talked about.
No, and I think that's one of the biggest problems around female bodies, female sexuality, is there's so much that's not talked about. So we just don't know. And I have so many different classes that I teach where people come up to me after and say, how have I never known this? How is it possible? I'm in my 40s or my 50s and I've never known this. And I think that this menopause transition is really one of those. So to clarify what these words mean, menopause is the time when periods stop. And it's usually 12 months after your last period.
That you're considered to be in menopause.
That you're officially considered in menopause, 12 months after the final period. So you can skip 3 months, you can skip 6 months, even 9 months, but once it comes back, the clock starts over again. Everything before that 12-month post-final period is considered premenopausal. From the time a girl starts her period up until that point, she's premenopausal. Postmenopause is from that 12-month mark past final menstrual period beyond. And then perimenopausal is this weird sort of gray, cloudy area when a woman might be able to tell that things are shifting, Maybe her periods are a little heavier or a little lighter. They come less frequently, or maybe even more frequently. And it can last 4, 8, 10 years before that final period. And I say that 4, 8, 10 in sort of a vague way, because I've seen all of those numbers in the literature. Mm-hmm. There is no one number that everyone seems to agree on of this is the time that a woman might be in perimenopause.
And this is also complicated usually by things that women might be doing to interfere with their systems. Like, for example, I'm currently on birth control medicine, which is a hormonal type of chemical, right, that I'm placing into my body. And if I understand correctly, it's helping me regulate and it's helping me continue to have periods. Is that correct?
Yes, although it's a bit of a false period, right? Because if you're on a hormonal birth control, what it does is it stops ovulation from happening. That's my understanding. So the period that you get is in that, say, if you're taking, or a woman is taking birth control pills and she has that placebo week where it's inert pills, then what's happening is she's just sort of faking her body into thinking that it's time to flush everything out. But it's not actually a true period of my body has ovulated, the uterine lining has built up, pregnancy has not occurred, and now the uterine lining is shedding. Does that make sense?
Yes.
Okay.
And why I can continue to do this past where maybe my body normally would if I wasn't taking these pills.
Right, exactly. And just as a disclaimer, I am not a doctor, so some of that description may not have been completely accurate. You know, I am a therapist, and this is my understanding of how this happens. So I apologize. Any mistakes I've made are mine. But I actually came to looking at this closely because, for a variety of reasons, I went off the birth control pill when I was 37, and I noticed when that happened, I did not have a regular period. I was having periods of 24 days and 23 days and 25 or 36. And then when I was 39, I skipped a period and immediately freaked out and went to the grocery store and bought like 3 pregnancy tests and kept getting the same answer of, I'm not pregnant. And everyone I told, all of my friends, their first statement was, you must be pregnant. And then I went to my doctor and I said, so I think this is what is happening. I think this is perimenopause. I keep getting a negative pregnancy test, but I just wanted to check in and rule out any other issues. And the first question my doctor said was, are you sure you're not pregnant? And I said, yes, I'm positive, but I'm happy to take another test for you if you'd like.
Right.
And then she said, okay, well, we'll do a thyroid test and a variety of other tests, all which sort of, to me, pointed to some fairly severe or unusual medical issues that might be going on. And then she said, worst case scenario is you may be right. It's perimenopause. And I thought to myself, why is that the worst case scenario? Because perimenopause would be a normal, natural transition that my body is just going through, compared to, say, a thyroid disorder, which would mean I'd probably have to be on a medication for the rest of my life.
Right. So what was the answer to that? Why is this the worst thing ever?
I don't know. And she never really was able to give me an answer of why that was horrible. And I think what it came down to is that if it was perimenopause, that I may have trouble getting pregnant. And she really seemed to, my doctor was female at the time, she really struggled with this idea that I might be okay not conceiving anymore and not having any more children. And that, to me, perimenopause was not a frightening thing. I just wanted to check and make sure that that was what it was. And what ended up happening was all my tests came back negative. Everything is perfectly normal. And she diagnosed, quote unquote, dysfunctional ovaries. Which I don't even think is a real diagnosis. I think that's what she just told me.
And is this because your age? So you're in your late 30s.
Yeah.
It's more expected, I guess, to be happening in your mid to late 40s. So you're about a decade early.
Exactly. Well, but if you look at, so everybody seems to think it's a decade early, but if you look at the mean age for menopause, the year after the last menstrual period, is 51 in the US. So if perimenopause and signs of shifting hormones can happen up to around 10 years prior, then I wasn't really that early. Being 39, I might expect to see something at 41. And maybe I'm just a little early on that spectrum. But I still get, now that I'm 42, if I go in for anything and they say, when was your last menstrual period? And I tell them it was 6 weeks ago or 8 weeks ago. They'll look at me and I say, I'm perimenopausal. I know I'm not pregnant. And they say, oh, you're so early. And you're so young. And these are medical professionals. These are nurses and doctors.
So this is like a big drama, like the fact that your body is going through this, I think what you're trying to say is my body's going through this natural process.
Right.
And it's kind of being shamed by the medical community.
Exactly. And every time I go in, regardless of what it's for, I have to answer these questions of, are you sure? Is this a thing? Oh, poor you.
And what is that about? What is the poor you about? Is it because we have such negative perceptions about menopause that somehow now you're going to be older? Or I mean, when you think about all the jokes, right? Or all the things that people say about menopausal women, they're not super kind. It's like, we're kind of like crazy, hot, flashy, bitchy, running around, angry at everybody,
depressed, angry. Yeah, exactly. And I think that it really shows the stigma of aging. So for me to go in now that I'm 42 and, oh, but you're so young. You're so young to be aging like that. And for me, I don't have a lot of emotion about it. It just is. So it's interesting to see other people's emotion being projected onto it when I'm coming from a very neutral place and I can see that this is really about your own feelings about aging. It's not about my feelings about aging.
Right. And so one of the points that you make too in the presentation is that because, and we can talk about the pros and cons, right? Obviously there's the whole idea of aging gracefully, accepting ourselves as we are. Why do we have to be different? Why do we have to fit some type of, I don't know, culturally ascribed model, right, of how we're going to age? And so just, let your body do what it's going to do and no big deal. On the other hand, most of us are doing certain things to help ourselves be younger or healthier or not have some of the maybe symptoms that come with aging, such as less energy. And I mean, whether it's exercise or using lube or, I mean, there's all kinds of things. And one of the things that's happened a lot for women is hormone replacement therapy around the time of either, perimenopause or menopause. So you made the statement in the presentation that hormone replacement therapy treatments have framed the medicalized understanding of menopause for like the last almost like 100 years, like 80 years or so.
Right.
So what are your thoughts about kind of the pros and cons of, on the one hand, we want things that help us. On the other hand, are we getting in the way of just understanding women just as women?
Right. And I think it's a little bit of both. And I think a lot of that really depends on the woman, the symptoms that she's experiencing, and the severity that she's seeing. I think there is use for them. And I'm certainly not one to say, no, you shouldn't, if someone feels really like this is appropriate for them. But I think that the medical system, and as you said, it goes back several generations now, 100 years, is really framed around men's understanding of women, because that's where it started. It started with men saying, this is what women should do or be, or how women are. And then as women have joined the profession and come into it, some of that has been taken on. And I think that we have to look at, is this really something that's serving a purpose, or is this giving us a false sense of youth that really isn't going to happen? And some of that is my own personal bias that personally, I don't want to live forever. I don't think that sounds terribly appealing. I don't feel like I need to look like I'm 20 until I'm 80. I'm okay aging and being who I am. And I think that while there can be some benefits, especially for women who are having very severe symptoms, when they're mild symptoms or moderate symptoms, why is our first inclination to put a medication on it? Whether it's a hormone replacement therapy or even birth control pills or an IUD. I know many women who, when they're starting to talk about irregular periods, their doctors first say, well, I can put you on a birth control pill and that will regulate your period. So, I just question, what is the purpose of that? Does that really help her, the woman, or does that just give a sense of things should be a certain way until everything stops? In which case then they're a different way. But then that doesn't really help her understand the transition that she's going through, either physically or emotionally, psychologically, in her roles and responsibilities. There's a definite life transition that happens that I think gets overlooked because we're so busy focusing on the symptoms.
Right. Okay, so given that you're not a doctor, but also given that you had some great charts in this presentation, can you walk us through some basic understanding about what's happening hormonally and anatomically during this time frame? How would you give us like a very basic 101 on that?
Well, what's happening is that generally we're looking at a woman who's premenopausal before she's hitting menopause or even perimenopause has a very predictable pattern in hormone levels, specifically estrogen, progesterone, luteinizing hormone, follicular stimulating hormone, I believe is what it is. And they come at regular intervals predictably through the month. And they will trigger ovulation, they will trigger the period, all of that. Then what happens is that during perimenopause, the hormones, they start coming very unpredictably. And so one day or 1 month, things may work really in that pattern that a woman comes to expect. And then suddenly the next month, it'll be chaos. And the hormones, the estrogen is really low, or the progesterone is even lower or higher, and everything gets out of whack. And that's part of what contributes to the irregular periods and the hot flashes and all of the other symptoms that she may notice.
Yeah, so there's definitely a level of discomfort that is normal.
Absolutely.
In other words, even premenopausal, while we're having our normal hormone fluctuations, there's areas of discomfort, right? I mean, there's discomfort when we have pains when we're ovulating or menstrual cramps, or just, a lot of women notice even emotional shifts, right? As their hormones fluctuate.
Right.
So this is kind of a lifelong relationship we have with our hormones as females in this regard.
And I think what happens is we get comfortable with the cycle of discomfort. And so a lot of women will say, oh, I know that I'm PMSing right now, so I understand why I'm cramping. I always cramp the first day or two of my period. So there's this predictability that happens that is comforting, even if it's comforting our discomfort. But when perimenopause hits, all of that gets thrown out the window, all of that predictability. Now we may not know when our periods are coming. We may have symptom changes. So a woman who never has had cramps before suddenly has intense cramps, or has very heavy periods, or maybe not very heavy periods, or maybe that varies from month to month. Or I know some women who never had pretty easy PMS symptoms, and then suddenly they're getting migraines regularly on a very monthly cycle. So when there's that sense of I don't know and unpredictability, it gets harder to manage what is happening here. I'm feeling really angry or really bitchy or irritable, and yet nothing's happening. Nothing seems to be happening, but there's a whole lot going on inside.
Right. It looked like from a lot of your charts, like the differences between, for example, something as simple as estrogen and progesterone, they might be fairly similar as far as those levels, but during menopause, there's like quite a bit of a difference between those two. And then that also can get back to a quote unquote normal after the initial menopause. Is that correct?
Yes. So what happens is that this period of perimenopause is very chaotic hormonally, and there's a lot of unpredictability. And then once menopause hits, all of those go down to a very steady level. So a lot of the symptoms that women experience in perimenopause actually go away after some time after menopause. I think hot flashes are the ones that can stick around for a little bit, but at some point they stop. And then the woman will experience a sort of constant state again, which women who are older talk about being very, like, once you get to that side, it's all easy going from there. And there might be some residual vaginal dryness or some sexual pain that they need to work with and they need to work around, but there's a predictability that comes back into life.
And how long does that stage usually typically last, that menopause stage where those hormone imbalances are still very much kind of off kilter?
That would be through perimenopause. So that would be the 4 to 8 to 10 years, depending on the woman. So it can be quite a long time. And part of the other thing that makes it challenging is there's no real test. There's no way to absolutely know. You can't go to your doctor and say, tell me that I am, because it all depends on the state of your body in that moment, right? So your doctor can take a blood test and can test your hormones, but that's only a brief snapshot of that moment. So I've had, over the last couple of years that I've been going through this process, everything from, well, your hormones are a little out of whack and everything's a little off and dysfunctional ovaries, to the most recent I got was your blood test showed completely menopausal hormones, that you were in full menopause. Well, I've been still getting my period. So clearly I'm not in full menopause, but on that day, that snapshot of my blood test showed that's what my hormone state was. But that also makes it really confusing for women on how do I treat this? And even for doctors who are not perhaps particularly skilled in it, like a primary care physician, might not have the full understanding of what those levels mean and what the treatment options are for that. So there's also a little bit about which doctor are you seeing, what are their specialties, how deep is their understanding of this perimenopausal state.
Right. Okay. So just to go through the symptom list, as far as what women can potentially expect, I mean, you will experience all these things, and you mentioned some of these. So irregular cycle, whether there's cycle differences, you skip, or your flow is irregular. Hot flashes, night sweats.
Good times.
Heart palpitations, facial hair growth, joint pain and or stiffness, vaginal dryness and atrophy. So do you want to talk a little bit about the difference between those two? What's vaginal dryness? What's vaginal atrophy?
Sure. Dryness is that there's less natural lubrication that happens. And atrophy is related but different. Atrophy is when there is so little lubrication that the vaginal tissues start to become more brittle and they tear more easily, which can then lead to sexual pain. So a lot of the treatment that goes into that is regular moisturizing. And there are some good over-the-counter brands that you can get at least many of the drugstores and pharmacies here in California, that it's just a little bit of, taking a little bit on your finger and massaging that into the vaginal and vulva tissues.
So inside the vagina, not just
inside.
On the vulva.
Exactly, inside the vagina. And then using lube and understanding that a woman can be aroused and feel arousal and still have no lubrication. And that those two things don't always go hand in hand. So having some lube available, and again, you can get some great ones over the counter at the drugstores, and just making those a part of regular sexual play so that pain doesn't become a regular part of sex.
Right. Okay. Yeah. And then to continue the list, there's headaches, breast tenderness, and insomnia. So you can see why, on the one hand, yeah, great, I want to gracefully age. And on the other hand, it's like, I don't want to feel these things, right? Like I take ibuprofen when I'm menstrually cramping, right? Or I don't want to necessarily have all of these symptoms because they're annoying. So it is understandable why women look for options, right?
Absolutely. And I think a lot of that question of, do I want to treat with hormones is really about how severe are my symptoms and how intrusive are they into my life, and how often do they last? So I've noticed in my own cycles that when I typically have night sweats versus the hot flashes, they last for a week or two. And it's a couple times a night, but I'm able to get back to sleep. They're not super intrusive. I don't find it to be something that bothers me that much. And again, it's only a couple of weeks, and then it kind of goes away and it fades back out into the background. I don't know if this will change, but at this point, I'm able to say, I think I'm able to manage these.
Right. Yeah, that's very personal.
Right, exactly.
For each person, right.
Exactly. And heart palpitations was another one that I experienced, which was a little bit more disturbing for me. And I had a really hard time convincing the couple of doctors that I saw that heart palpitations was actually a symptom of menopause. I was practically at the point or perimenopause. I was practically at the point of bringing in journal articles and saying, no, see here, it says perimenopause and heart palpitations can go together. Because, and I appreciated that they were wanting to take it seriously as a potential heart issue. But when all of my tests kept coming back negative, and they were, they did not want to look at that possibility. And again, I found it really coming at this place of, I know a little bit about what I'm talking about, even though I'm not a doctor, give me some credit. And they just didn't want to go there. But I can appreciate that a lot of these things are not comfortable. They can be disruptive. And I think everybody has to make that decision for themselves about, how bad is this? How severe is this? What is my understanding of what's happening to me and my body?
Right. Well, there's psychological indications as well, and you list those out. So going down that list, there's potential for more anxiety, even panic disorders, depression, mood instability in general, irritability, forgetfulness, which I notice a lot, and insomnia, which again, sometimes these are hard because it's hard to sometimes weave out what's going on in your life in general versus
Absolutely.
what's going on, especially during a 4 to 10 year period.
Yeah.
So these can get kind of hard to parse out.
And the studies are a little bit inconclusive about these psychological indicators of, are they truly symptoms of perimenopause, or are you experiencing them because you're having regular insomnia, or because you're having headaches and migraines, or because you're getting confused because you just had a hot flash and now you're a little bit embarrassed and uncomfortable, and where was I? What happened? How much of it is because of the physical symptoms that are happening that are creating a psychological effect, or how much of it is the psychological effect on its own? And we do see a lot of doctors also prescribing antidepressants in this time period. Mm-hmm. A lot of people who use antidepressants in this country are women in their 40s and 50s. Mm-hmm. And so there's some question of, again, what exactly are we treating? Is this, I'm depressed because I haven't been sleeping well, because I'm having regular night sweats? Or is it something different? Is it true depression, which an antidepressant might be totally appropriate? Or are we treating the symptom of something else? But in the meantime, she's now putting this chemical into her body that's having other things that's impacting sex and her relationship, because now her desire is lower because of the antidepressant, and it might be a drug that she then has difficulty getting off of and then feels the need to be on for a decade or more. So it's this really complicated picture that in parsing out how much of it is this piece versus this piece, and what is the appropriate treatment? What's the best treatment for these things?
Right. Yeah. And I think even just from a developmental perspective, I mean, when you're in your 40s and 50s, you've got kids who are leaving home, you've got teenagers who are sassy. A lot of times you're dealing with your own identity questions, right? So,
and you might have aging parents who need additional care at the same time that your kids are going through this chaotic time, and it's our own. Often we're having career changes at this time because we've reached a certain point in our career where we're now saying, okay, what's the next step? Or we've reached a certain point in our parenting where we want to put more time and attention into our careers. So there's a lot of stuff going on.
Right. May not be willing to put up with things that you used to put up with.
Exactly. Yes, absolutely.
Right. I tend to see that pattern. All right. Well, so this is, Mormon Sex Info. So let's talk about the sexual kind of effects. Like, what do people notice in their sexual lives during this time?
Well, we talked about the vaginal dryness and the atrophy and the pain. That's probably one of the biggest things that women talk about with their doctors and therapists. And again, that's where the hormone replacement therapy has been found to be helpful, because it does help keep that lubrication and keep the tissues soft and pliable. But again, we also, we've talked about some of the downsides of that, and there are health issues that I don't fully understand. Women might be at more risk for heart disease or breast cancer. And again, I don't know those, and that's a better question for somebody's doctor. But so beyond that, the pain, there might be also diminished desire, which again can also come with a busy life. So how much of that is because of busyness versus pure sexual issue or perimenopause is sort of hard to know. The hot flashes can be an issue, because hot flashes they're triggered by our environment. So to some degree, if you have a hot beverage, you might be triggering a hot flash. One of the things that I've read in some of the studies is that what happens is women's temperature threshold drops a little bit. So things that she might not have found overwhelmingly warm before now suddenly are. So when you're having an intimate moment with your partner, it's natural that blood is going to be moving in a different way, and you might feel flushed and warm. That can trigger a hot flash, which is not necessarily a turn on to suddenly find that you're a sweaty mess in the middle of an intimate, sexy moment.
Right.
And then if you're having pain or the diminished desire, there might be issues with arousal or orgasm, because it's harder to get to that level of pure enjoyment. And then at this time of our lives, often our partners might be having their own sexual issues. Men can experience greater issues around erectile dysfunction, and might find they're more sensitive to other things. And I have heard of men who become so fearful of causing their partner's pain that then they experience their own challenges with erection, which is not related necessarily to them, but it's an effect of not wanting to hurt their partners. So it can also get a little bit complicated there of, chicken and egg, which one came first. And then there's the effects of fatigue or depression or irritability. And I just don't want to have sex because I'm too irritable and I'm in a bad mood and I don't want to.
Right.
Yeah.
Yeah. And so let's talk about that for a little bit, again, from this acceptance model versus challenging model, right? So a lot of people, I think, might get to this stage and say, yeah, I've done the sex thing, not interested anymore. I'm getting older. I'm just going to go with the flow. And it's, even thinking from the perspective of my Mormon lens, some women in particular, I think, that come from religious cultures or even religiously conservative cultures, sometimes were never really taught to prioritize their sexual lives for themselves to begin with.
Sure.
So it can be kind of spouse-centric, or unfortunately, a lot of women are kind of involved in duty sex, right? Or just make my partner happy. They reach this point and they're like, I'm done with it. Maybe sex was fine when we were younger, or when we were trying to create a family, or the procreative kind of processes. But now I'm done. I never really enjoyed it to begin with, or maybe there were aspects of it that I enjoyed, but not to the point that I really want to challenge these physical symptoms. So there's that whole perspective.
Absolutely.
Versus the perspective of sexuality being part of our overall health, and that, kind of like anything, if you don't use it, you're going to lose it type of mentality. That's true of our muscles. That's true of it's why sitting is the new smoking, right? Is that what I'm
right?
So,
yeah, exactly.
If we want these things in our life to work, we have to kind of prioritize it and make it, something that we're intentional about. So thoughts about managing kind of this, I'm just getting older, I'm going to accept that I'm not as sexual as before and I really don't care, versus maybe this is something I should care about.
Well, I think a lot of that goes back to, as you said, what was the perspective when she was younger? So if duty sex was always a thing and she's never enjoyed it, and it's never been something that's been pleasurable or that she's seen much of a purpose with beyond making a spouse happy or procreating, then I don't know that there's going to be a huge shift at this point in her life. I could actually see it being a relief. Oh, thank God. I'm done.
Right.
And I think that coming from my therapy background, I totally respect that, and I don't know that she would come in looking for something different from me. So I don't know that there would be much I could do. Now, if she wanted something more, then I think there's a lot of room there for, well, what do you want and how can we get there? And how can you come to a place of find pleasure now that, does it have to be a duty? Can there be, what have you gotten out of it in the past? Have you ever gotten a sense of pleasure out of sex, whether that's emotional pleasure, connection with your partner? Is there anything that he does that might feel pleasurable, arousing, sexy, good? Can you connect to that part of you? And I think that that's something that often I hear, especially with people who are struggling with the desire of, I want to want, but I don't want. But I think there's a lot of room for, okay, well, if you want to want, that's a good place to start. And I usually use a lot of mindfulness for that in trying to get women out of their heads. I talked a little bit earlier about busyness. And we get so caught up in being busy, the things we have to do. My children have this tomorrow. There's this other thing. I have to run this errand and I have work and I have this and that and that. How do you focus? So I help women kind of quiet that and get in touch with what's happening in their body and what does arousal feel like in their body, getting out of their head and into their body when they're experiencing physical sensations.
Yeah, I love all that. And it is a time of life where, maybe you are an empty nester, maybe the kids are more independent, although we're still always busy. It doesn't seem to matter what time of life.
Yeah.
We stay busy.
Yeah.
But you can maybe be a little bit more self-centric, in
Absolutely.
the sense of now it's my turn. Now it's my time to prioritize things that matter to me. And even things that maybe don't seem as directly related to sex, but are still taking care of your physique and your body, going to the spa, getting a manicure, getting a massage, taking time to go work out. Those are all things that you're doing to prioritize your physical self, right? Which then indirectly relates to your sexual self.
Right.
And even some of these partner relational problems don't have to be as awful. Like if he's having a little bit of erectile dysfunction, well, maybe now he's lasting longer, right? Or maybe now you're having to figure out different ways to pleasure each other. And so it's kind of a new time to regroup. And
I think there is a time of exploration.
Mm-hmm.
There's a lot of, okay, that's who I was. That's who we were. We've spent the last 10, 15, 20 years, 25 years, 30, focusing on our family and our children. And now that's not there to the same degree. So who are we? Who am I? Who do I want to be in this next phase of life? How do I reconnect with my partner in a way that's not child-centric? It's not about co-parenting. It's not about the business of running a household. It's about, you know what? Hey, we made it. Yay, us. We've raised our children. They're in university. They're doing their thing. They're living their lives. Now, who are we as a couple now? When it's more about us than about the business of raising kids.
I love that.
I think that can be a time of a lot of excitement and possibility and newness. And just to say, you mentioned exercise as self-care. Exercise is also amazing to treat depression, anxiety. All of these symptoms can be decreased with exercise.
Yeah.
And that's not a magic pill. It's not but some women report that there's a big difference. They sleep better. sleep better means less depression, means clearer thinking, means better body image, which means our self-concept is more positive, which sometimes means we feel sexier, right? Again, it's all intertwined.
Not to mention that orgasm can help with chronic pain.
Yes, exactly.
Headaches.
Exactly.
And
Yeah.
it's good for your cardiovascular health.
Right.
A lot
Yeah.
oxygenates the blood through going through your system. And so there's lots of health benefits, obviously, to even if you're not necessarily reaching orgasm, just the pleasure of arousal has these benefits. Yeah. You asked some questions here as well that I think are just good to throw out. What does it mean to be quote unquote old? I think you mentioned ageism earlier. It's just, we have so many cultural stigmas and stereotypes about what it means to be old, and somehow getting older desexualizes you, which is so unfortunate, because it is a time where many, not everybody, but a lot of people have more financial means, have more time, have more ability to focus on their own personal goals. And so it can be a very exciting time. And the fact that, as a culture, we desexualize people is unfortunate. Of course, a lot of people I talk to at that age don't care about that as much. That's one of the other benefits of getting older, is like, who cares what other people think? I'm going to
Exactly. I think it's actually harder for people who are going into those years than for people who are on the other side, because I've heard that same experience of like, whatever, I'm going to do my own thing. I've lived this long. I've earned the right to be who I am.
Right.
But I think, some of the studies that I've seen, it's younger women who struggle more with the idea of menopause and what does menopause mean. It's the women who are in their 30s and 40s who are struggling with this idea of, another year. What does that mean? What does it mean to get old? Yeah. Can a woman in her 40s be sexually vibrant? Can she be found attractive?
Yeah, and we know the answer is yes. I mean, people are having wonderful sex lives reported into their 80s and 90s. So
absolutely. But because we don't talk about sex in our culture, we often don't know that that's happening unless we look for it. So those of us who are in the field and are doing the reading and looking for it know it's happening, but the average person on the street doesn't know. And they say, oh, well, no, my grandparents never had sex. Are you kidding me?
Right. It's a whole other type of therapy, right? Is
exactly.
You have to figure out your trauma around your grandparents or parents' sexuality.
Right.
Well, and another piece I want to talk about, because again, in Mormonism, this is so prevalent, is the identity of motherhood is so important to Mormon women, to Mormon families. This is true, again, of lots of religions, Catholics and Judaism and Islam. And so a lot of your identity is tied to the procreative part of yourself, the mother identity, the parenting identity. Sexuality is very interwoven in that, right? And so as you hit menopause, it's kind of an end of an era. It's your system saying you're no longer in this space where that's going to be where your identity is so caught up on that particular part of life.
And I think it's natural to have a lot of grief about that and loss. And there is a shift in letting go and how do I say goodbye to that piece. But I think it's also where a lot of women get caught is they get stuck in that grief. And they get stuck in that was all I had. That was who I was for so long. And then there's never quite the next step, because part of transition is grieving what was, grieving what is no longer, and then saying, okay, but now I'm going to turn toward my future. And to go back to those existential questions of what do I want to be? Who do I want to be in this next stage of my life? Because I am still a vibrant, passionate, powerful woman, and I may need to redefine myself a little bit. But that is possible.
Right. Yeah, I couldn't agree with that more. You have a quote here by Huffman in a research article, I'm guessing. It says, for women who have had to cope with racism and sexism, menopause may represent one more sociocultural hurdle that threatens their well-being. Do you want to speak a little bit about some of the challenges that we're not necessarily getting at that are kind of interwoven in the complexities of other aspects of life?
The problem is when we look at cultural issues, there may be less education around bodies. There might be more stigma around sex or sexuality or physical forms and what our bodies do. And that lack of information can really cause problems. When we've talked about being aware that hot flashes happen and they come and go and not feeling like it's a permanent state, that's really comes out of education. So if you don't have the education or the mentoring from women in your community, you might not realize that. And it may play into this greater sense of ending. And when we're looking at other racism or sexism, womanhood in different communities can mean different things. And our expectations of women in different communities can be vastly different, which means our understanding of what happens with age can be different.
And I'm guessing also access to healthcare, access
Exactly.
to resources, depending on socioeconomic status,
Right.
geography.
Yes.
Yeah.
Yeah. And if you don't have access to a really great doctor who can help you parse out what are your options, maybe you're having severe symptoms of perimenopause and you're having the horrible hot flashes and you're having the really heavy periods and you don't have access to hormone replacement therapy. Or the very first thing your doctor says is, well, you should have a hysterectomy because that's just the easier thing. And maybe that is, or maybe is it really easier for the woman or is it easier for the doctor? Because it's the easy answer. And now she's undergoing this radical surgery that's invasive, that takes time to recover from, that maybe isn't the best option for her. But that, because of access, that was the only option she had. So she took it. And again, it's, maybe that is the best option, but I think it's different when you only have that one option given by the one provider that you maybe have to drive far for versus living in a metropolitan area with good health insurance where you can get second opinions and you can talk to different specialists to find out what their opinions are. And you have a full range of treatment options available for you.
Right. Yeah. All right. So to close up then, let's talk about, so what do we do about all this? So you mentioned kind of some coping resources. You even had a bit of a model that you presented in this presentation. Do you want to talk a little bit about kind of just a systemic approach to looking at all these different factors we've been discussing?
Sure. I mean, I think the first place to start is, what is your perception of what's happening to you, to your body? And that's going to be different for everyone. Some women might find that it is an ending. Some might find it's a beginning, or it's a non-thing. It just is. And that's really going to define what she needs. If she finds it a neutral or a new beginning, she probably will have an easy transition. If she finds that it's an ending and there's a lot of grief and loss, or that there's a lot of very significant symptoms that are happening, she may need more. And then it's really about seeking out the support, whether it's family and friends or community, the medical community, religious institutions, or if there's women's groups that she belongs to. That's a place that she might be able to go to get support and to get information and camaraderie. Even when somebody says, oh yeah, I went through that, I get where you're coming from. That can be really powerful and take away some of the isolation that can make the symptoms feel worse. And then some of the other things to be aware of is that each individual is going to respond differently based on their personal characteristics or their psychological history. And some women might find it beneficial to go to therapy in order to talk through some of these role changes and perceptions and stresses and the other things that she's experiencing. Mm-hmm. And that therapy may help to smooth the road a little bit.
Including even sometimes relationally, people are not very kind.
Right.
You have a spouse who really puts you down for having, going through these changes, or so
right.
if you're in any type of a toxic relationship or relationship that's not supportive of you, that's another reason to seek out that type of help.
Right, exactly. Or if it feels like sex really is a challenge and you're wanting more and really not wanting to see it just go away and not feeling relieved at that, then that would be another reason to seek out some help, either through a medical professional who might be knowledgeable about that, or a sex therapist who can help problem solve and figure out what are the areas that need to be worked on, whether it's communication or timing, or how to fully experience arousal so it's less painful, or to use lube, some help with that.
Right.
And a lot of this is about understanding the situation. What can she control? Are there areas of her life that are stressful that she can kind of grab hold of and manage that? Are there healthful habits that she can use by eating a balanced diet or getting exercise? Can she work on her sleep habits? Drinking less, should she drink? That can be helpful as well. And then understanding that, the control and the modifying of the situation are really important. Where can she grab control when her body is feeling so out of control? But sometimes even understanding, there are things that you can do to help the rest of life feel so controlled, so that when you have the hot flash, it doesn't feel like it's as big of a deal, or you can roll with it.
Right. Yeah, so you just kind of went through the 4 S's model, which comes from Anderson, Goodman, and Schlossberg. So situation is what you started with, right? Is how's the situation being perceived? Support, what kind of support networks are there? Self, so what types of personality traits or characteristics or psychological issues are going for the self? And then strategies, which you've given us a lot of great ones to think about. So thank you so much. This has been really helpful and really educational. I hope that people find this really useful. Do you want to give us some closing thoughts as far as just, if you could have a soapbox and, and say, this is what matters, or this is something I really want you to have stick out of this entire hour?
I think the most important thing is to remember that this is actually really normal. I've had so many women say, what I'm experiencing is not normal. And I remind them, actually, it is normal. This is what bodies do. This is what our bodies are meant to do as we adjust from our childbearing years to our non-childbearing years. There's a little bit of chaos, and that's okay. That just breathing through that chaos and knowing that it will end eventually can be really powerful, and that this is normal, and that every woman goes through this to some degree or another, and that they will survive it.
Yeah, I agree. Even, your initial comments about it being seen kind of as a medical condition, it's not really something we need to, like you mentioned, treat. It's more something that just needs to be managed because it's just a normal part of life. Yeah.
Yeah.
Thank you so much. I really appreciate your time and coming on. I know.
Thank you for having me.
So thank you.
We took the long road home, turned minutes into miles, and as the evening traveled on, the sunset bathed your smile. We stopped beneath the desert stars, wrapped in each other's arms. Was as simple as I love you, an ordinary, extraordinary truth.
A trail with tears, pain and sorrow too.
But through every storm we traveled on, like lovers do. And if sometimes we fell I love you. An ordinary, extraordinary truth. Some people say love is blind and forever is too long. But I see your eyes in every sunrise. Can't imagine life alone. Let's take the long road on together until we're gone. Want you by my side till the day I die and into the beyond. It's as simple as our love is. That's how I wanna go, all wrapped up in the arms of our extraordinary, it's nothing ordinary love. Ordinary. No, it's extraordinary.